All right, let's go ahead and get started. So thank you everyone for joining the Undiagnosed Diseases Network Grand Rounds. We're really looking forward to having the Duke Clinical Site presenting today. I'm going to go through just a few overview things about the UDN before we go ahead and get started. So next slide, please. So just wanted to give folks an update. These numbers come from our quarterly report, which are available on the About Us section of the website if anyone is interested in diving into the report in more detail. At this time, 30% of our participants who have received a remote, in-person, or research evaluation have received a diagnosis. And those who have had exome sequencing, 35% have had at least one diagnosis made through that sequencing. And of folks who have had genome sequencing, 20% have at least one diagnosis made through sequencing. And then we have just about a little over 500 variants that have been evaluated by the UDN's Model Organisms Screening Center. The UDN's mission is to improve the way that we can diagnose and care for patients with undiagnosed diseases, facilitate research into the causes, as well as creating an integrative and collaborative research community to do this type of work. Next slide, please. And for those of you who may have not caught up with us in a little while, the UDN has grown in some ways. So you can check out more information about our clinical sites, our research cores, sequencing core, and data management coordinating center on the website as well. But this is just to show you where everything is at right now. Next slide, please. And today, during our grand rounds, if you can ask questions via the Q&A text box, and we'll save the questions for the end, and we'll ask those for the presenters. The information in today's talk is presented for informational and educational purposes only, and information can be used for personal uses if the content and references remain unchanged, and no part of the presentation can be published without prior written permission from the UDN. Next slide, please. And so with that, I'm delighted to turn it over to Vandana Shashi and Rebecca Spillmann, who will be speaking today. And without further ado, I will turn it over to you two. Thank you.
Thank you, Emily. Our goal today is to talk about solving patients who come in with a non-diagnostic exome or genome sequencing. This is the perspective of the Duke UDN Clinical Site or Diagnostic Center of Excellence. So we have three objectives today. The first is to kind of go through with you the nuances in variant analysis and interpretation, both in exome and genome sequencing analysis, so that you understand the difference between variant detection and variant prioritization as two broad reasons for why an exome or a genome can be non-diagnostic. We also want to emphasize the importance of the UDN N of 1 approach rather than a cohort approach that helps to resolve non-diagnostic exome sequencing. This is time consuming and intensive, but it does help resolve many cases. And then we wanted to briefly talk about, with case vignettes, the limitations of exome sequencing and genetic testing through clinical laboratories. Clinical laboratories do an amazing job, but just due to the nature of what their priorities are and how they're set up, diagnoses can sometimes get missed. So to give you a little bit of background, we all as clinicians and researchers know that the vast majority of individuals who have exome sequencing or even genome sequencing tend to have a non-diagnostic result, with 50 to 75% being in that category. For patients who have a non-diagnostic result, the next option can be a time-lapse clinical exome reanalysis or genome reanalysis, and that can yield diagnosis in 10 to 15%. And genome sequencing is an obvious next step for those who have a non-diagnostic exome, and it can provide an incremental diagnosis in 5 to 10%. In the UDN, it's probably a little higher than that. But beyond genome, we do have a lot of emerging diagnostic tools, such as optical genome mapping, long-read sequencing, epigenetic profiles, but these are still very much in the research realm. We just don't have enough data, and they're not enough validated to be clinically employed or to be widely employed. So the question still remains, how can we increase diagnosis from exomes and genomes and conserve further resources? So the Duke experience has been that most of our patients at this time, or all, are coming into the clinical site with a prior non-diagnostic exome. Cumulatively, we've accumulated 181 patients that fit this category. And when I say ES, it also includes non-diagnostic GS in a few. And this graph here shows how we started off with 60% having a non-diagnostic exome, and then that number has gone up to about 100% of patients who enter the study have either a non-diagnostic exome or a genome. And we defined a non-diagnostic exome or genome as one where there were no variants at all reported, or if reported, the variants were not indicative of a diagnosis. When we looked at our data, what we found that of these 181 patients, we were able to diagnose 71, and that gives us a diagnosis rate of 39% in this group. We compared this diagnosis rate to patients who came into the study without having any prior sequencing, and the rate for them is higher, obviously. It's 50%, which is understandable, but the difference between the two groups of diagnosis is not significant. So we're doing quite well with trying to diagnose individuals who come in with non-diagnostic sequencing. So the 71 patients that got a diagnosis after non-diagnostic exome genome had 74 diagnoses, and we did a retrospective review. And all 71 patients met the following inclusion criteria. They had to have pre-UDN non-diagnostic exome or genome. They had to have obtained a certain highly likely or tentative diagnosis. These have been previously defined in the UDN. I want to note that the tentative diagnosis was only in the case of 5 out of the 71 individuals, and they're all novel candidate genes that we have not yet published, but very confident will be new disease gene associations. But we've communicated these as tentative to the families till that point. And all of the patients had to be enrolled in phases 1 and 2 of the UDN. We obtained from the UDN gateway a lot of information, including demographics, the type of NGS that had prior to the UDN, their phenotype, and UDN-related genetic, non-genetic tests, as well as sequencing that was done through the core laboratories of the UDN. We also looked at our own results of our clinical site reanalysis of pre-UDN non-diagnostic exomes and genome, as well as our reanalysis of sequencing data that was generated by the UDN sequencing core laboratories. For each of the 74 diagnoses, we individually reviewed each one to see, could this diagnosis have been amenable to prior exome sequencing? And that included looking at the type of the variant, the inheritance, and many other variables. Was the sequencing a trio or not? And when we did decide that a diagnosis could have been made by prior sequencing, we wanted to know the reasons for why it had not occurred. And this included a discussion with the laboratory that had performed the pre-UDN ESGS. This was not always feasible, but wherever possible, we contacted and spoke with them to get their perspective. And we'll illustrate this with some case examples. So if you look at the characteristics of the 71 diagnosed patients, they were not significantly different from the ones who were undiagnosed. Of the 181, 110 still don't have a diagnosis, but they're very similar to the diagnosed patients in terms of the age distribution. Most were pediatric, 54% were male, most were white. We had relatively low Hispanic population participation as well. Most came in with neurological symptoms, and most were referred by their geneticist. Second most common referring provider was their neurologist. Interestingly, 92% had had prior chromosomal microarray before entering the UDN, and that had been non-diagnostic as well, no CNVs. And for the exome and genome sequencing, 80% had had trio sequencing, and 69% had either clinical or research exome sequencing, and 2 had genome sequencing before that had been non-diagnostic. And a quarter had also had reanalysis of their exome data before they came to the UDN, and that also had not revealed a diagnosis. So when we looked at the methods to diagnosis for these 71 individuals, they had 74 diagnoses, and this could be characterized as follows. Broadly, the methods were using sequencing data reanalysis with our phenotype agnostic research pipeline. This helps us not filter out variants based on phenotypic mismatch. This yielded the highest rate of diagnosis, 53% of the diagnoses, and this involved getting FASTQ files both from the outside laboratory before the UDN as well as within the UDN from the sequencing core laboratory, and we did our reanalysis. The asterisk refers to 6 patients in which we did not have to do a formal reanalysis, but there were variants reported on the prior exome that were interesting to us. We curated and pursued these further with research, and they did turn out to be diagnoses. The second methodology that yielded the most diagnosis was going on to clinical sequencing through the Baylor lab as part of the UDN evaluation. That led to 21 diagnoses, and 20 of these happened through genome sequencing. One was an old exome that we repeated, and we did get a diagnosis. Then third methodology was just not doing any sequencing, but actually doing targeted testing. For example, the phenotype dictated a specific disorder. So for those, we were able to do a targeted test and got 5 diagnoses. And the other 2 were not sequencing, but they were genomic tests, such as optical genome mapping and a chromosomal microarray in one patient who'd never had that before. And we did it to complete it, and we got a diagnosis. And interestingly, there were 6 diagnoses out of the 74. These were individuals who had prior non-diagnostic ES, where the diagnosis was based on clinical signs and laboratory tests that were non-genetic, leading to diagnosis that did not require sequencing, for example, an autoimmune disorder. So then the question came up was how many of these diagnoses had been overlooked in the prior sequencing, or they were just not possible by prior ES or GS. So for that, we excluded the 6 cases where we had a clinical diagnosis and only used the 68 that were genetic out of the 74. And the inheritance of these were autosomal dominant was the most frequent, most being de novo. We had recessive as a next frequent, and 5 were X-linked. And we looked at 81 variants across those 68 diagnoses in great detail to figure out the reasons for why those diagnoses had not been made. And what we found was the first category was the variant was just not detected previously, and that was about 40%. And most of these were variants that were not amenable to, say, exome sequencing, like trinucleotide repeats, and in older ES, CNVs were not well detected. And there were some non-coding variants. But we did also have some coding variants that should have been picked up that were not detected. For example, variants in GC-rich regions. So there were a variety of variants that were not detected previously. And then the larger category was a variant was not prioritized for reporting by the previous lab. So this category was defined as one where the variant was detected, but it was not recognized as being pathogenic, likely pathogenic, or VUS, so never appeared on the report issued by the testing laboratory. And some examples were synonymous variants or variants where the lab thought there was a phenotypic mismatch and they just did not report it. And we'll give you some examples of these. So after reviewing all 68 diagnoses in great detail, we determined that 47, that's almost 70%, that involve 54 variants should have been found on prior, or should have been reported on prior ES or GS. And this graph here gives you a breakdown. Those are the 47 that were tractable to exome sequencing with 54 variants. And we broke them down into known disorders. These are disorders for which there's a phenotype association with the gene, and then novel genes where there's known human disease association. And they were about half each. The disorders that were known, there were many reasons for why the variant had not been reported. Most of this is because this was the largest category. They were not prioritized, the variants, because of poor phenotypic fit. And then the next most common cause was at the point of reporting, there was not a gene disease association for that particular gene. We had a few cases of mosaicism, and then we had others that were not easily groupable, and we called them technological limitations. For example, not the lab had considered the canonical transcript, but when we considered the more relevant biologically relevant alternative transcript, the variant was indeed pathogenic. So we had some of those kinds of reasons. For the novel gene, almost always, it wasn't because the variant wasn't detected. It was because it was not prioritized for the simple reason that it was in a novel disease gene and they did not want to report it. There was one individual who had GS. Remember, I told you we had 2 in this cohort who had prior genome. This one individual with the genome did have a CNV within a gene that was a novel candidate, and the lab at that time was not doing CNV calling, so they didn't report it, but we felt like it should have been tractable to GS in general. I don't have time to go over all the variants, but in essence, the non-prioritized variants were mostly coding SNVs. Most of them were missenses, but there were also some nonsense variants that had not been prioritized for many of these different reasons I have categorized here. There were also some non-coding, such as splice variants at the exon-intron boundary that should have been tractable and were detected, but were not prioritized. So we'll move on to the case example. The first one is a child where variants were detected but not prioritized because of a phenotypic mismatch and the nature of the variants. These were compound head variants, both were synonymous, and one was classified as likely benign and the other was a VUS. So this is a 9-year-old boy who was adopted from China. He had short stature, microcephaly, unilateral coronal synostosis, many dysmorphic features that you can see here. He had digital anomalies, moderate hearing loss that was mixed in nature, vertebral fusions, pancreatic insufficiency, and mild developmental delays. His pre-UDN clinical ES was non-diagnostic. It was a singleton because there were no parents available. So we obtained the FASTQ files from the testing laboratory from outside and reanalyzed it through our pipeline, and our bioinformatician highlighted this synonymous heterozygous variant in the gene CDC45. The TRAP scores and splice AI scores were high, indicating it was probably involved in splicing, but the variant was not present anywhere. So we knew nothing about it. Biallelic variants in this gene cause an entity called as Meyer-Gorlin syndrome type 7. It's a new entity described in 2016, distinguishing it from the other 7 types of Meyer-Gorlin syndrome. And in the paper that had described this, there was a missense variant at the same residue as our patient that caused amino acid substitution that was shown to cause splicing functionally on functional assays. So this was very interesting to us. But there was no second variant. Then we compared our patient's phenotype, facial phenotype, to those published in the paper, and they were similar, as was his growth pattern. Then when we put the features our patient had in relationship to MSG7 that had been published in that one paper, the most often reported features were short stature, microtia, and patellar hypoplasia, aplasia. We didn't know if our patient had this. We knew he had short stature. He really didn't have microtia, but he had unusual ears. He did have craniosynostosis and some hearing loss that had been reported. Then we had done a skeletal survey as part of the UDN evaluation, and it had been reported as normal. So we went back to our radiologist and said, can you take a look at the knee views? And he did. So this is the view of a healthy 9-year-old where you can see the patellar ossification. And then this is our patient where this is absent. The radiologist said they had not picked up on this because they don't do lateral views of the knee as part of the skeletal survey. But it was clear that this was a finding and it was consistent with the diagnosis. So we wanted to find the second variant at that point. So we ordered commercial Sanger sequencing of this gene, looking for del dupes and SNVs, and nothing new was reported. They just reported the variant we already knew from our bioinformatic assessments, and they called it a VUS. Then we did genome sequencing at Baylor. It was non-diagnostic. The same variant was reported as a research variant. We did RNA-seq through UCLA with a collaboration, and we asked them to look at the consequence of this variant. And indeed, they had very few reads, but they thought it was going to cause it caused an exon skipping. Then we collaborated with the group that had published the paper on this disorder in New Zealand, and they agreed with the clinical diagnosis and offered to reanalyze genome data. I have to credit Kelly Shuck, our genetic counselor. Many of you on this call know her. She worked on this case, and it's due to her credit that we found a diagnosis. Unfortunately, Kelly's not able to work with us anymore because of a medical reason, but this and many other cases are illustrative of her great contribution to our UDN side. So Kelly was determined to solve this case. So she did many things simultaneously. She asked for our site to reanalyze the genome data that we had generated through Baylor with focusing on this gene. She sent the genome data to the collaborators in New Zealand. And she went back to Baylor and said, can you please look at this gene? We're really interested. And she talked to Lee Kai at UCLA saying, are you seeing anything with RNA-seq analysis? And all of these efforts simultaneously led to the identification of a second variant in the gene, which was also synonymous, but predicted to be benign and really wasn't bioinformatically that interesting. It was seen 32 times in East Asians. So then we thought, okay, can 2 synonymous variants be associated with this condition in our patient? Because most synonymous variants are neutral. If they do affect the gene, it is through RNA mechanisms. And then we looked at the literature again, and indeed, there were 3 synonymous variants in this gene in 3 other patients with this condition in trans with another variant. And so these variants can cause exon skipping. So we worked with the New Zealand group, Dr. Louise Bicknell's lab, and she did a mini gene assay for that second variant we had found that was thought to be benign. And indeed, it does cause skipping of exon 16. There's another variant that she had identified in another patient that was also causing the same exon skipping. And then when they did an RT-PCR, they saw that the transcript was reduced. So we had two synonymous CDC45 variants resulting in exon skipping. So we went back to the clinical lab that performed the prior exome, and they had not reported either variant. So the reasons they gave us was that they did not know about craniosynostosis or hearing loss prior to analysis. So this gene was not in their, highlighted to them in any way as being one they should be looking at. They did note the heterozygous VUS, the synonymous one, but because it was a single variant in an autosomal recessive gene, they did not report it. Their analyst noted it could be considered for reporting if a reanalysis was requested in the future. And the other variant was filtered out as likely benign. We had to give this diagnosis to the family, but these one was a VS, one was likely benign, but they were still research studies that we had done. So we went to the commercial lab that had done the Sanger sequencing and asked them to issue an amended report for this second variant. And they declined because they were still interpreting it as likely benign. They were aware of a paper in which there was a fetus that had one of this variant in trans with another variant, but there was no functional assay for the variant. Then we shared the information from the mini gene assay that we had showing exon skipping, and they gave us an amended report, but they still called it as a likely benign. And the other variant was still a VUS when we went back. But we were still able to give this to the patient as a clinical and molecularly confirmed diagnosis. It was very time intensive, required multiple modalities of testing, collaborations, and it is caused by synonymous variants. And one of those is a founder mutation, the second variant, the histidine to histidine. There are 3 Chinese families with this variant. And exon skipping is relatively common in this disorder. So with that, I will let Becky take over.
Thank you, Vandana. There we go. These next 3 cases we're going to present, 2 of these cases were not included in the 74 diagnoses we presented earlier as they came out during the cutoff for our data collection. But this still does highlight this continues to be a struggle with the UDN of diagnosing our negative ES patients. So case example 2 is variants were undetected in targeted testing and exome sequencing due to technological limitations, and the phenotype really led us to a clinical suspicion of his ultimate diagnosis. There we go. So our patient is a 10-year-old male. He was referred to the UDN due to a progressive neurological disorder. His symptoms included a hand tremor with gait ataxia, dysarthria, and hypotonia, absent reflexes, and a sensory neuropathy on EMG. Some of his prior testing included an ataxia panel, as well as trio exome sequencing, which were both normal, non-diagnostic. Based on his clinical presentation, we were suspicious of Friedreich's ataxia. However, the FXN gene was included on the ataxia panel, and that was negative. So I'm going to play a short video clip showing some of his presentation. The family lived outside of North Carolina, so we decided to proceed with a remote evaluation. He had a very engaged neurologist who was able to assist us with some of the pertinent evaluations we were interested in. We were most interested in getting an echo and EKG done to check for a cardiomyopathy, given our suspicion for Friedreich's ataxia. That was done relatively quickly, and the result was left ventricular hypertrophy. Given his clinical presentation and now this new heart finding, we decided to proceed with remote collection to move forward with trio genome sequencing rather than doing a reanalysis of his previous exome. We got in touch with Baylor and asked them to pay particular attention to the FXN gene based on our clinical suspicion. And on trio genome sequencing, he came back with two rather large expansions in the FXN gene, 1197 from mom and 1183 from dad, providing him a diagnosis of Friedreich's ataxia. As you recall, we said he did have an ataxia panel done, which did show negative expansions in the FXN gene. So we went back to the commercial laboratory to share these results with them. They redid the testing on PCR with their original primers and again obtained a normal repeat size. They did the testing with alternate primers and was able to detect the expansion. They did issue an amended report showing these expanded repeats. In communication with them, their best guess was that the patient may have had a SNP in this region that interfered with the original primers with the amplification. He's now followed with the CHOP Friedreich's ataxia clinic. There is an approved medication for individuals 16 and older that does seem to help slow the progression of this condition. It's not yet approved for kiddos. There are ongoing clinical trials to get this medication approved for kids, and the family is hopeful that he'll be able to enroll in those trials. He does have two full younger siblings who were subsequently tested based on this result. His younger brother, who showed no symptoms at 7 years old, did test negative. His younger sister, during the time of our patient's UDN evaluation, did start showing some difficulties in walking, and she was shown to have the two same expansions and was also diagnosed with Friedreich's ataxia. I do want to highlight that our patient's mom is on the call today, and she was so gracious to share some photos with them. They were able to take a Make-A-Wish trip last year to Universal Studios. Our patient loves the beach and loves the water, as you can see from his pictures swimming. They had a wonderful vacation this year. And again, mom is on the call, so if anybody would like to say anything to her in the chat, you're more than welcome to. She is a wonderful advocate for her kiddos and really goes to the end of the earth to make sure her kiddos get the care that they need. Oops. Okay. Let's see if I'll go backwards. Our third case example are compound heterozygous variants that were detected but not prioritized due to the variant being found in controlled databases and the other variant being considered a VUS. Our patient was a 2 years, 9-month-old Caucasian female who was referred to us due to micronathia noted at birth. She was having feeding difficulties, choking and desaturations, and was noted to have aspirations needing G2 placement. Subsequently needed a mandibular distraction. However, that did not really improve her feeding. She was noted to have macrocephaly, some dysmorphic features, generalized hypotonia, and some minor delays, though it was felt that her cognition was in the normal range. Some evaluations that occurred before she was enrolled in the UDN, she was found to have conductive hearing loss. Neurology felt that she had normal facial movements, but with generalized hypotonia. The geneticist had suspected Mobius syndrome, though she did have normal extraocular movements. Brain MRI showed a right subdermal hematoma and decreased central white matter. Spinal cord MRI did diagnose a syrinx, and she did have tether cord release surgery that greatly improved her motor development and her gait and walking abilities, and was subsequently also diagnosed with sleep apnea. Some of her prior genetic testing had included a normal microarray, myotonic dystrophy testing, and UBT14 testing, which was normal. She underwent a trio exome sequencing in December 2021, which was non-diagnostic with a blank report. She also underwent a reanalysis of that exome data in April 2023, which was also non-diagnostic with no new variants reported. So for her UDN evaluation, The family lived further away and was in another state, so we opted to do a telehealth examination. I will say it was one of our more interesting evaluations as we caught the family while they were on summer vacation and they were at a campground. The mom was kind of chasing our patient around with her phone trying to get a telehealth examination, but we got the best we could. She was noted to be macrocephalic with a long face, tall forehead, broad nasal bridge. She had had that surgery, so there was no obvious micronathia, but was noted to have low-set cupped ears. She did have clearly campodactyly of the left third and fourth fingers with some hypotonia. Given the timing of when she had had her most recent reanalysis of her exome data, we had elected to not do a research reanalysis of the exome and decided to move forward with trio genome sequencing. So trio genome sequencing was done in December 2024, and she came back with compound heterozygous variants in the MYMK gene, providing her a diagnosis of Cary-Feynman-Zeider syndrome. This condition is a well-published condition with the first clinical description being published in 1982. However, the gene for this condition wasn't identified until 2017, known to cause mild non-progressive myopathy with facial weakness, Rowan sequence, and Mobius sequence. Again, as a note, her exome sequencing initially was done in 2021. Her reanalysis was done in 2023, and the first case report of the MYMK gene came out in 2017. So we emailed the commercial laboratory that had performed the exome sequencing and the reanalysis. They said that these variants were detected, but were not selected for reporting in the initial analysis or the reanalysis. They noted that mom's variant had been found in the homozygous state in controls. And while dad's variant was bioinformatically interesting, but because mom's variant was filtered out due to the homozygous state in controls, they weren't going to report a single heterozygous variant in an autosomal recessive condition. At the end of the day, they said that this was human error was the reason that the variant was ultimately not reported. The maternal variant is found in 2 individuals in the homozygous state in Nomad. However, the maternal variant has been published repeatedly as a known recurrent pathogenic variant for this condition and has been published as being hypermorphic in that first 2017 paper. Of note as well, there was some clinical factors associated with this variant not being reported in her initial exome sequencing and reanalysis. Some of the clinical features of the patient were not suggestive of this condition, and some of the features that she had were not provided to the laboratory. She did lack Robin or Mobius sequence, though the geneticist did note that he had suspected Mobius sequence. That information was not presented to the clinical laboratory. While she did have micronathia and mild facial weakness, which is noted in this condition, she also had some nonspecific features, including hypotonia, developmental delays, and macrocephaly. The MYMK gene is still very rarely reported. There's very few probands reported with this disorder in the literature, making recognition of this condition difficult. As more publications have come out, we are also noticing that there are more mild phenotypes, and there was more recently a individual in his 60s who was ultimately diagnosed with Cary-Feynman-Zeider syndrome with a much more mild phenotype in his 60s. Of note, he did carry this same recurrent variant as was found in our patient. The last case example we're going to present today are, again, variants detected but not prioritized due to a lack of gene disease association and the delay of updating literature in an analysis pipeline. So our patient was an almost 4-year-old Caucasian male with IUGR and failure to thrive, microcephaly, dysmorphic features, and severe developmental delay. He was noted to have multiple congenital anomalies at birth, including horseshoe kidney, hemivertebrae, xiphoid process cleft, and sacral agenesis. He had an abnormal brain MRI consistent with a Dandy-Walker complex, as well as no cranial nerve identified in the auditory canal, leading to congenital bilateral sensory nerve hearing loss. He was also noted to have multiple heart defects. Some of his pre-UDN testing included prenatal microarray as well as postnatal microarray. Due to the phenotypic overlap with Johansson-Blizzard syndrome, they had direct targeted testing for the UBR1 gene, which was normal. He underwent trio exome sequencing in November of 2019, as well as exome reanalysis in November of 2021, with no new variants reported. We saw him as part of the UDN. He was noted to have short stature with pretty significant microcephaly, thin, sparse hair. Some of his dysmorphic features included hyperplastic eye with short and beaked nose and a long philtrum. He also had a tented upper lip with a vaulted palate, and I tried to show in the picture here some of his conical shaped teeth and his lower incisors. He had significant hypotonia and decreased muscle mass and DTRs. Again, due to the timing of when his most recent exome reanalysis had occurred, we had elected to not move forward with a research reanalysis and decided to move forward with trio genome sequencing. So we sent trio genome sequencing to Baylor in May of 2022. And he was found to have a homozygous nonsense variant in the CAPN15 gene, providing a diagnosis of oculogastrointestinal neurodevelopmental syndrome, OGIN. The initial paper describing CAPN15 gene as associated with OGIN was published first in September of 2020. As you might remember, his initial exome sequencing report was issued in November 2019. So his initial exome sequencing occurred a year before this gene was known to be a disease-causing gene. However, the second paper expanding on the phenotype of OGIN was published in January of 2021. And his exome reanalysis report came out in November of 2021. So in the time between he had his initial exome sequencing and his reanalysis, there were at least two papers describing this as a disease-causing gene, as well as even expanding on that phenotype. So we went back to the commercial lab that did the initial exome and the reanalysis to learn more about why the CAPN15 homozygous variant was not covered. In review of their data and their notes, they said from the initial analysis, the variant was a candidate gene, but there was no disease associated with the gene at the time, so it didn't meet their threshold for clinical reporting. From the reanalysis, in the lab's database, the gene was still marked as a candidate gene and had not yet been upgraded to a known disease gene. Per the lab, the gene was upgraded the very next day and in hindsight would have been reportable. So there was a significant delay in incorporating new literature into their analysis pipeline with, again, the initial paper coming out in 2020, a more expanded cohort coming out in January 2021, and the exome reanalysis coming out 9 to 10 months later. Interesting to us is the proband's mom, when she arrived at our UDN evaluation, turned out to be pregnant. So there was many conversations regarding recurrence risk at the time, as we had not had a diagnosis for him when he was evaluated. Subsequently, when we provided the diagnosis of OGIN, which is an autosomal recessive condition, we did do risk counseling and discuss the risk for this pregnancy. Though it was noted she was monitored very closely, and so far the pregnancy had not noted any IUGR or any congenital anomalies that were detected during the pregnancy with our proband. Subsequent testing was done following the birth, and the patient did not inherit the CAPN15 variant. So in conclusion, approximately 70% of the diagnosis that we made after a non-diagnostic ES could have been amenable to exome sequencing. Most involved non-prioritization of variants, rather not detection due to ES technology. Clinical laboratories are wonderful, and we would really be lost with them in genetics without them, but they are focused on certain priorities, including high throughput, consistent turnaround times, and cost efficiency. This does mean that variants may not be prioritized by clinical labs for a lot of different reasons, including a perceived phenotypic mismatch, variants that are found in control databases that they're utilizing, delayed in updating their pipelines with interim literature, novel candidate genes or variant types, including synonymous variants. And we cannot speak highly enough about these intangibles. Variant curation is really an art, and it's something that geneticists and genetic counselors take very seriously and work really hard to learn using all the bioinformatic tools available to us. But it's still, at the end of the day, a judgment call of what is ultimately prioritized. The N01 approach that the UDN uses to help diagnose after a non-diagnostic exome includes research reanalyses and further phenotyping that really does help increase this diagnostic yield. Follow-up with clinical labs we have found to be really invaluable. We can call them and ask about specific phenotypes, ask about specific variants that they may not have been reported. This open communication between us and additional commercial laboratories can be very helpful. A caveat we wanted to note is that this has been the data we collected was from the beginning of the UDN up until now. We know that exome sequencing and analysis have gotten better over time, with now even CMV detection getting better. So some of the variants that had initially been undetected in our study may have been reported from its current platforms. And we wanted to thank everybody on our UDN team, as well as our UDN families who trust in us to help, get them diagnoses. We also wanted to thank our UCLA team that helped us with the RNA sequencing, and our Baylor, it's not going backwards, and their Baylor sequencing core lab who provides the genome sequencing to us.
Wonderful. Thank you so much to Vandana and Becky for very interesting cases and walking us through what happened with each of those. We have one question so far in the Q&A, so we'll go ahead and start with that one. But as a reminder, please, for any questions that anyone has, go ahead and put those in the Q&A and we'll get to them. And so for the first question, it ties nicely into that last case you presented, Becky, but I think the question was more about the aggregate data that you presented early on. Has your group been able to correlate the date that the exome report was signed out with the date that the variant turned out to be diagnostic in the literature or in ClinVar?
Becky, you want to answer that one?
We do go back and we do take the dates into consideration of when reports come out. We can't fault clinical laboratories or the people if the variant hadn't been reported previously. So we do go back and check those dates when we're communicating with commercial labs and laboratory and patients.
And I think one point, testing to clinical laboratories getting better and better over time. What we have found is our clinical site reanalysis in the beginning phase of phase 1 and even into phase 2, the yield was quite high of us finding something. With time, that yield has dropped, that reanalysis of outside data. And I think that also attests to the clinical labs reporting more. I think where there is a lot of variability in reporting is novel candidate genes. It's very variable. And also the phenotypic mismatch is a big factor that labs may not prioritize something. That still continues to be an issue.
Thank you. And that's actually a great segue into mostly a comment from Cindy Tift. I think the fact that several cases involved phenotypic mismatch to the commercial lab emphasizes the importance of good phenotyping and recording of that phenotyping on the lab requisition. I don't know if either of you want to make any additional comments on that.
Absolutely. And I think for clinicians also, if you have a particular phenotype in mind, we are all rushed. I've had this experience in clinic too. On the requisition, you just put something. Sometimes we send our entire clinic note, but the lab might not go through all that. If you're considering a very specific phenotype / disorder, I think it merits talking to the lab after you get that non-diagnostic report to see, was there something that they didn't think matched the phenotype that they thought was important. For example, the last case that Becky presented of the CAPN15, that was the homozygous nonsense variant. And the lab yet did not report that. In terms of inheritance, it's a recessive thing, and the variant was clearly a deleterious variant, and especially on reanalysis. So I think having that conversation really helps.
Thank you. So this is a question from a new parent seeing the UDN soon, so a new participant. How often are these tests performed using blood versus skin or tissue biopsies? And they add that they've been torn about putting their child through a biopsy, but don't want to lose the possibility of a diagnosis through that, and knows that this is highly specific to the individual, but would love any of your insights.
Becky, you can take that one.
Sure. So we have actually, most of the testing we do is on blood. So I will say most of the testing we do is on blood, or if remote, we do saliva samples and cheek swabs. Though I will say that we had 2 diagnoses where the exome initially came back negative, and we did testing on skin samples, and it turned out that the diagnosis was due to a mosaic variant that was too low-lying mosaicism in the blood to be reported out, and we were able to get the diagnosis on skin. So like you mentioned, it is very specific. I think your UDN team and your genetics team would be able to walk you through the benefits or pros and cons of doing a skin biopsy, but I would say most of our testing is done on blood or saliva cheek samples.
Thank you. The next question is, has your group updated the approach of genome first and start with exome reanalysis, given that 70% of the variants you found by genome could have been detected retrospectively by exome sequencing?
I'm not sure if I understand. Are they asking, have we updated our approach to include reanalysis first?
Yeah.
That's always been our approach. We always look at it, how old the report was, whether there was a reanalysis done, how recent was any of those things. Was it a trio as opposed to a duo or a singleton? Those are the factors we take into trying to do a reanalysis. And if we think it's valuable, we always do that first before we move on to genome.
Yeah, for two of the cases that I presented, the reason we hadn't done reanalysis was because the reanalysis by the commercial lab had been done within a year. And we thought that the index would be low of us detecting something that the clinical lab didn't. So we decided to move on to genome sequencing. In hindsight, we probably would have detected those variants on our reanalysis. But given the time frame, that was the way the decision was made.
That makes sense. Has that example case changed at all your timeline that you consider for starting with reanalysis, even if there was one done previously, or no?
It's in the back of our mind now, always. I will say we really take such an individualized approach on each case. We really talk about each case during our team meeting. It's interesting, we are getting more genomes now than exomes with our patients coming in. So I think where we may have moved away from doing exome reanalysis, now patients are coming in with genomes. So I think we are reconsidering again, getting that data to do genome reanalyses before we would move on to something like a long read or optical genome mapping.
Great, thank you. The next question is, have you seen cases with larger CNVs that were not previously reported by array or exome genome that were ultimately diagnostic?
Go ahead, Becky, you know these.
I was going to say, so we have had some instances with using optical genome mapping that have helped us detect deletions that were missed from genome sequencing and from a microarray. We know that genome sequencing analysis is continuing to get better, as is exome. So it'll be interesting to see in the future if some of the larger deletions that we saw from optical genome mapping would have been covered by genome. But yes, we are seeing those.
Great, thank you. And then thinking about conserving sequencing funding and using it most appropriately, should we consider emphasizing reanalysis of existing exome data as opposed to ordering a new genome? It seems that even recent clinical reports may have successful reanalysis after careful phenotyping.
Yeah. It's definitely something that we are considering. Our UDN funding continues to change. And how do we utilize that funding best? I think one thing that Dr. Shashi tried to note is that our reanalyses are also very time intensive for our clinical team. When we get that reanalysis back, we get a lot of variants. The individual variant curation we do is very time extensive as well. So I think it's finding that happy middle ground of what is the best bang for our buck, if we should say, is sending off a genome versus doing a reanalysis in the past year. Make the most sense. But it's definitely something that we're considering. Again, now that we're getting more genomes, doing a reanalysis of them versus maybe repeating a genome is something we're definitely thinking about.
And I think when requesting a clinical reanalysis, in addition to a time-lapsed one, which has more value, I think giving clinical labs based on what we saw, an updated phenotype might also be a helpful thing to guide them.
Yes, great point. Thank you so much. I think we're out of questions. I don't see any new ones in the Q&A box, so we'll go ahead and close there. I want to thank you both so much, and to everyone at the Duke team for all of your work on these cases.